Welcome to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are excited to be discussing clinical reasoning, Dr. MJ Sacco and Dr. Andrew Parsons. Will each of you please introduce yourself? Tell us about your clinical interests related to today's topic and something you enjoy outside of medicine.
Sure. Hi, I'm MJ Sacco. I'm a pediatric intensivist at the University of Virginia Children's Hospital. I'm also one of the associate program directors for the residency program there. And then Andrew and I work together in my role as the director of the Foundations of Clinical Medicine course in that medical school. My interest is in teaching clinical reasoning and its applications to clinical medicine. And then I think you asked me to come up with one fun thing about myself outside of medicine. I'm actually contractually obligated to tell you that I do CrossFit. Yeah, look at Andrew's face. I do CrossFit to keep myself, I'm like a border collie. If I don't have something that I'm chasing outside, I'm really hard to be around. So that's what CrossFit does for me.
It is so important. So important that you notified us early of that.
Yeah, don't worry. I'm going to bring it up at the answer to every question. As a CrossFitter, I think about it this way.
Of course.
Hi, everyone. I'm Andrew Parsons, internist, specifically hospitalist at the University of Virginia with MJ. And I'm also our Associate Dean for Clinical Competency for the School of Medicine, which focuses on clinical reasoning, teaching, assessment, remediation, as well as coaching. And used to be more involved on the GME side, focused on remediation. So I'm all about helping struggling learners, both students and residents. But my research focus is around remediation, but also around management reasoning, which I think we'll talk a little bit about what that is later. And outside this, I just started playing soccer again. But I, more than that, have a 10-year-old daughter and I like watching her play soccer.
Oh, nice. Well, that sounds like a difficult job, and we thank you for your service there. As we get to know you guys, you've both been really involved in teaching people how to be doctors, boots on the ground. Are there any life advice, whether it's a favorite failure or a favorite lesson that you'd like to share with the PedsCrit listeners?
I'll jump in because I actually was thinking about this ahead of time and I just heard this. I don't remember where, but it was a saying a week ago or so. And it was fail early, learn early. They said it like it was a well-known phrase. I don't know if it is, but I had never heard it before. But it resonated with me just from my own experience, but also this topic. It's like when you're afraid to fail, that's when you really get yourself in trouble. But when you're willing to like put yourself out there and struggle, and then you can have a growth mindset and like quickly grow from that and improve. That's, I think, like relevant to what we're talking about today with clinical reasoning and struggles related to that, but also just in all aspects of life. So I liked that quote.
Oh, yeah. Mine is from fellowship. We had a peds anesthesiologist who would bring patients back to us. Sometimes he would surprise you with a little fentanyl push without telling you, and you'd have to react. The patients always did fine, and it was never dangerous. I want to be very clear. But he would say to us, hey, I'm never going to let you get yourself into a situation I can't get you out of. And that has been like my guiding light as an educator, especially in some place like the PICU. I'm never going to let a trainee, a fellow, resident, med student get themselves into a situation that I can't bail them out of. That's my work. So I think establishing that up front makes everyone feel that it's okay to be pushed because I'm in control.
I feel like that's empowering for people to function at their highest level, right? If you tell them, in my mind, there's a range of right answers here, and then whatever you choose, I'm going to make sure it's safe. That really allows people to create their own management plans and see the fruit from those decisions. Well, as we get to our topic today, any conflicts of interest to disclose?
Nope.
No, I'm not in the pocket of big clinical reasoning.
No money in clinical
Wonderful.
reasoning.
Big clinical reasoning.
Alice, you want to give us our first case?
Yeah, let's do it. So this is case number 1, early trainee with a diagnostic error. We've got a 2-year-old girl presenting with irritability, tachypnea, and mild work of breathing in the middle of RSV season. She started on high-flow nasal cannula admitted to the PICU. Some nasal congestion is noted without crackles or wheezing or increased respiratory effort. The nasal RVP comes back from the ED and is negative, and the trainee evaluates the patient and suggests that we should continue supportive care because it has to be bronchiolitis, right?
Until it's not, yeah.
Until it's not. So this is someone who's coming in, they've been given a diagnosis, they're carrying it forward. What's the possible diagnostic error here?
This is a good one for us to talk about why I think the PICU is such a great place to evaluate people's clinical reasoning skills. As an intensivist, one of our favorite sports is to maybe poke fun at the NICU doctors down the hall. And in the NICU, they do a great job at management, right? They see the same 5 or 6 diseases and they're exquisite managers. And I think that's true, and it's something that they should be applauded for. Please don't tell anyone at UVA I said that. And I think in the PICU, you never know what's going to come in the door next. So the diagnostic part of things in the pediatric ICU is really important. And I think this gets to the idea of trainees, when they come to the PICU, are usually second years. Occasionally, you have a skilled medical student doing an elective. And at that stage of their training, they're really trying to balance type 1 and type 2 thinking. Let me tell you what I mean by that. Type 1 thinking is that smart, fast heuristics. I got a baby, they're snotty, their lungs sound like a washing machine. It's November, this has to be RSV. Type 2 thinking is this more deliberate, slow-paced thinking where you really want to back yourself up and say, what could this possibly be? It's way more labor-intensive. It involves you going through like a set system in your mind consistently over and over again. I think at the end of medical school, like fourth-year medical students and interns, they feel like they're supposed to be all heuristic, all type 1 fast thinking. I think that's what's happening to this trainee, is they want to come up with a fast, correct answer without doing the necessary slowdown to say, am I missing anything? And I think that's what we're seeing in this trainee.
So just reflecting over the course of my very short career as a fellow going into a new attending, as a fellow, I did feel like I stayed in the type 1 thinking quite a bit. Generally they have it set up where there's so many sick patients to take care of, and you kind of bounce from one patient to the next. You're doing great procedures and resuscitations and all that stuff. But what I've noticed as an attending, as soon as there's time for a pause, I have found myself swapping back over to type 2 thinking. That more comprehensive, what am I missing here? What am I not considering? And I think this case with the patient who's wheezing and having some work of breathing, it could be a number of things. It's probably viral, but gosh, this is how foreign bodies, this is how vascular rings. So there's so many more sinister things that also present in the same way.
Well, and especially if you read the case, hey, the patient's actually not wheezing. So maybe somebody told you they were wheezing, but now the work is on you to say, is that true? And how does that change my management? But I think you're exactly right. I mean, Andrew and I talk about this all the time. Heuristics, type 1 thinking is really easy when you're tired because it's low energy. And so when you're a trainee, you really want to bias towards that. And type 2 thinking really requires a lot of intellectual fortitude to slow yourself down and think through.
What level was this learner again? Did we say that?
Like an intern or,
like an intern?
Early second year in the PICU.
Yeah. Because I like to think of this as, is it a knowledge issue or is it a process issue? And I think we jump to process issues, or we jump to bias. Like you could say, is this premature closure on bronchiolitis? Or you could say, is this confirmation bias because they have a test that suggests it's not, but they're still sticking with it. And it could be those things for sure. Maybe we'll talk more about cognitive bias as we go along. The interesting thing to me about cognitive bias, there's a whole literature out there on efforts to fight cognitive bias, like debiasing strategies, they're called. And it never works no matter what we do. And so it's kind of come back to, well, maybe all of it's more knowledge issues. And so that's what I wonder in this learner. Is it because bronchiolitis comes to mind easy for them? They know it's RSV season. Everybody's talking about it, but they can't actually think of anything else. And so I think that's helpful framework to think about, because if you say, well, they're thinking type 1 versus type 2, and we just need to tell them to slow down and engage their type 2 thinking and be a bit more deliberate about what they're doing. Well, one, that might work for this case, but they won't know when to slow down in the future and when not to slow down. And two is even if they slow down, if they still don't know things, now they're just slow and they don't know what they're doing. So it could be that they haven't thought about the differential early on and expanded their differential enough through using, different techniques that we could talk about. And so they don't have something else to jump to when a test comes back and unexpectedly negative.
Yeah. How do you tease that apart? Say that Saturday morning you're rounding for the first time, early in the fall, your first time working with this second year resident. How do you start to tease that apart? Do you ask follow-up questions? Do you push them? Do you kind of wait and get to know them over the week and see?
Well, I'm not patient, so I'm probably going to ask the follow-up questions right away. I'm also really interested in this. And Andrew brings up a good point of this idea. Is it medical knowledge, or is it a processing or scaffolding problem that they have? I think for too long we settled in on they just need to read more instead of really digging in. And so this is an opportunity to say, well, what else is on your list? And again, this is a good time to say the ER told you it was bronchiolitis, or your sign-out told you it was bronchiolitis. If you were meeting this patient fresh, what goes for or against that? What else is on your list? Really forcing to explore how their brain is processing. I love analogies. In my mind, I think of trainees' brains as closets. Medical knowledge is, do they have enough clothes in their closet? Do they have enough types for all the different kind of weather that they're going to see? And then clinical reasoning is the schema that they use to organize their closet. So if I send somebody to go pick out an outfit for gym class and they show up in a ball gown, I'm going to say, you've got a lot of medical knowledge in there, but you don't know how to access it.
Yeah.
So this is where I'm going to explore that with this learner. What's in your closet? Do you have enough knowledge in there? And if the answer is yes, well, then I'm off to the races with I got to work on their scaffolding. And if I say, what else is on their list? And they think, I only know bronchiolitis. A, we're in deep doo because I missed that as an intern when I was taking care of them as a program director. And B, now's my chance to sort of work through where their knowledge deficits are.
Yeah, and I think it's important to move up this process as much as you can kind of in their decision-making process as well as in the patient encounter, right? So that you don't wait until a test comes back negative and then you say, well, what else could it be? You really want to be there with them at the beginning. This patient comes in, you just know a little bit of information about them and their chief complaint. And it's like, okay, what's your differential? No, make it broader, make it broader, make it broader. You think RSV bronchiolitis is first on your differential, so you want to order this test. Well, if it comes back negative, what's your next step? And therefore, what are you going to go to right away? So I think pushing them to like go through that mental exercise, but pushing them to think out loud from the beginning there, so there's a full plan as you work your way through, can get at, do they kind of just give you that blank stare back when you say broader, broader because they don't have the knowledge base? Or is it a process issue where they're just, as they navigate the case, they're prone to certain biases or going in a different direction? And I think that could be really helpful. I mean, Zach brought up an interesting point, like as experienced clinicians, we can toggle back and forth between type 1 and type 2. And most of our errors, right, come from being too intuitive, like our pattern recognition's failing. So we're like, well, if I just slow down, it was more deliberate, I could do that. And so I think that leads us to tell our learners to do the same thing. But again, if they don't have the knowledge, then slowing down's not going to help them that much. So we have to give them like a framework to build out that differential. And then it might be actually go read more, but it's go read more about this chief complaint in this specific type of person, not go read more about bronchiolitis. So.
And I also think by the time learners come to the PICU, it's a second year rotation for most people. They've taken a lot of tests. They've taken a bunch of in-services. They've had a lot of time for us to establish, do they have medical knowledge deficits? So most of the time in the PICU, it's not medical knowledge. Most of the time, it's going to be a processing problem. And then Andrew's point's a good one, that you got to make that diagnosis early, because if I spend a whole month trying to teach somebody processes and they don't have the clinical knowledge to scaffold off of, I've wasted a whole month of their learning.
It seems like some of the pearls here as educators, we need to maybe even have a type 2 thinking approach to diagnosing the deficit in the trainee. So like it's so easy when they get a case wrong to say it's a medical knowledge problem. We need to be able to tease the nuance out. Is it a medical knowledge or is it an organization of that knowledge, the scaffolding, so to speak? And it seems like one of the better strategies that each of you have used on rounds to help trainees organize their thoughts is this Socratic method when you ask questions one after another to help them, piece it together. Some trainees do really well with this, but I find that other trainees, maybe it's just how medical school is designed where there's so many tests, there's always averse to getting stuff wrong. How would you perhaps make that trainee feel more open and comfortable experimenting being wrong and exploring and like putting their name down on what they think is possibly going on?
Yeah, this is fast failure, fast learning. To me, this is all about setting expectations. When you come onto a service or a learner comes onto your service, it's right away, they're usually asking you, or they're trying to kind of guess what you actually care about, right, compared to somebody else for right or wrong. And to me, I usually say, I want you to think out loud. Like that's the main thing I care about. And I'm not judging right or wrong. I'm really just judging if you're not telling me what you're thinking and you're not trying to justify your decisions. And so like, let's throw it out there. Let's have a great conversation about why and why not for each thing. And then I like to push them to look into the future, as I just kind of highlighted. If they say they want to order a test, okay, well, what do you expect that to show? What if it doesn't show that? Like play things out in the short term.
I feel like it's really easy to see how this translates over really nicely to rounds. MJ, I want to ask you, say you're resuscitating a patient with respiratory failure. And if a trainee could look inside the gears in your mind and see how you're toggling back between type 1 and type 2, how over the course of resuscitation do you think you approach that patient with each type of thinking? Is this like your type 1 for the first hour and then your type 2? Or is this like a 5 minutes of critical type 1 and then a little bit of type 2 and then back to type 1? Does that make sense?
Yeah, it does. I don't think it's like now I'm in my type 1 zone, so I can't take type 2. I think when I'm resuscitating somebody, I am using type 1 thinking, fast thinking, to come up with what's going on. And then I'm using type 2 to do some hypothesis testing. Okay, if this is a foreign body and I'm bagging them, I shouldn't be seeing bilateral chest rise.
Yeah.
Okay, if this is bronchiolitis and I'm bagging them and I don't have to use a lot of pressure, I'm guessing wrong. So I think that that's what we're doing in critical care all the time, is that we come up with our hypotheses pretty quickly and then we slow down to test them. And then I think if you've run out of your heuristics, I mean, the great news about critical care is, I mean, we're going to give Lasix or we're going to give fluid. And if we chose the wrong one, we're just going to choose the other and it's okay. Yeah. I mean, that's part of that fast failure is really is the name of the game. But as you're diagnosing somebody at the bedside, trying to get to the cause of what is happening, you're going to use your management, you're going to use your strategy as hypothesis testing to help know if you're on the right track or not. And I think that's why critical care is so attractive to me. When I think about like what developmental pediatricians have to do, hey, I think this medicine might help you. Give it a try for 6 weeks and let me know. Wow, that takes a lot of skill that I do not have. I need to know right away.
Yeah, tight evaluation and management loops, right?
Yes.
Evaluation, management. Yeah.
And it's just hypothesis testing all the time. We have the privilege to work in like the coolest physiology lab in the hospital. No offense, Andrew, because we have all this awesome physiology. And if I'm right, if you are dehydrated and I give you volume, your heart rate should come down.
But there's a big like cognitive leap. Like you said that with such simplicity and such like really when a patient becomes very sick, right? Our options actually become pretty limited. And there's just a few things we're going to do and we're going to judge their reaction to that. And that management's going to inform our diagnostic reasoning. And I love that too about urgent situations. But I find that like, especially struggling students or residence fellows, like it's so hard for them to get from what we're teaching them that's very knowledge focused and then like diagnostic reasoning focused to get to that level where you're like really seeing the big picture. Because what you're doing is you are definitely not getting lost in the
sauce.
Exactly. Like you're looking at the big picture and the main thing we need to do right now is improve their blood pressure or get fluid off of them and see how they respond to that. Even though there's 1,000 kind of underlying pathophysiologic things going on at the same time. So like to be able to like offload that to focus on what really matters is a huge skill.
Oh yeah, that's why it's a 3-year fellowship.
Yes. I think one take-home point here is being able to communicate the nimbleness from jumping from type 1 to type 2 thinking. And the pitfalls here, I think, as trainees will sometimes find is they haven't developed that type 1 thinking quite yet, especially if they're really early on in their training. And then when like really urgent scenarios arise, there's a bit of a freeze because I haven't got the labs yet, right? I haven't ordered the CMP, et cetera. Or the other side of this is, I'm in type 1, I'm type 1, and it's not working and I'm done.
Yeah, I don't have any way to bounce back and forth between the two. I find that most of the time with peds residents, once they've developed their heuristics, they feel like that's what's expected of them. They should just know it. And it's on the attendings to say, oh no, I back off and think, what the hell am I missing all the time?
Yeah.
And phone a friend, right?
Yeah. Oh man. Yeah, my first 6 months out of fellowship, I must have called my fellowship faculty once or twice a month to say, am I doing this wrong?
Oh, yeah.
Who amongst us?
I'm texting. I'm reaching out.
Yeah.
This is also, I will say, this is one of those things that can't be replicated outside of taking care of patients. And the more patients you've taken care of, the better at this you will be, right? This is not something that you get perfect at or even learn about in theory and then put into practice.
I totally agree. What I say to MJ a lot is like, it's context. And if you look at the clinical reasoning literature too, it's all moving from like knowledge to the importance of context. And a big thing there, like I didn't want to gloss over what Zach said earlier, like you differentiated knowledge amount versus knowledge organization. And I don't think most people acknowledge that distinction. Like, because when MJ earlier was saying this person needs to read more, the assumption there is like they don't have enough knowledge. And she was saying rightly that like most of the time that's not true, right? But it's not the amount of knowledge, it's knowledge organization. And to me, that knowledge organization is not just, yes, reorganizing what you learned in like early med school or residency to be able to apply it in the clinical environment. It's like all the unique situations. Like you have to have that scaffolding from this unique situation that could be an urgent encounter or an emergent encounter. And like you can fall back on that scaffold to inform your decision making.
Yeah. It's not just organizing it into, okay, cardiac, metabolic. It's like outfit clusters, right?
Yes.
Like it's like, okay, for these kids, I always think about these 7 things, right? Like,
yep. And it's not guidelines, right? And it's not like evidence. It's not textbook. It's 4 different things are going on at the same time and this person's decompensating. So what are the practical things we need to do next?
Wonderful. Any more diagnostic reasoning tips for move along?
My biggest tip I think that I want to leave everyone with is emphasizing the number of times I've said to trainees, what's your diagnostic system? Like, do you use like the adult internal medicine guys love like Vindicate? I don't love that one. I go head to toe and think through in each part of the body, what is this? When I say to learners, do you have a system? They'll say, yes, 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 yes. And then I'll say, what's your system? And then they can't demonstrate it or explain it. And that to me, in the question of, hey, how would you coach this learner who got stuck on bronchiolitis? I mean, when I wrote this case, the diagnosis is DKA. Mm-hmm. So, right, it's an unusual age in the wrong season, but that's how that disease presents. As soon as I get the students to slow down and really go through their systematic approach, and then I ask them to do that over and over again for a couple of weeks with every patient, I see their diagnostic acumen, like you can watch it grow before your eyes. It's really gratifying.
At that point, you give them the head-to-toe systematic approach.
Mm-hmm. I say, like, I start at the head and I think, what's in the brain that could be making this patient breathe fast? What's in their airway that could be making this patient breathe fast? Is there anything in their mouth? Is there anything in their throat? Is there anything in their lungs, heart? And then I just go down. And that to me is easier. And I let the endocrine live in the adrenals because I'm an intensivist, right? That's the only thing I care about is cortisol, somewhere. Right? So, so that's how I organize it.
Oh, I like that.
To go bigger than that, right? Because I think MJ and I think about this the same. It's early hypothesis generation and it's hypothesis-driven data gathering. Because I think traditional teaching in med school is like you go in, you do a full history, you do a full exam, then you come out and you have all this data and you think about it. And that does not work. And that's not exactly how we do it, how like any practicing clinician would do it. It's utilizing your knowledge to have a really broad differential from the very beginning, even before you walk in to see the patient, and then use that to inform the questions you ask in the exam that you do. And then I think in urgent situations or emergent, you do that on a sped up timeline.
A smaller list that you get through faster.
But you're acknowledging there that you're mostly type 2 because you haven't honed your pattern recognition yet. And so you're going to be deductive and you're going to be testing each one of those hypotheses when you go in. But if you do that enough, then you're actually honing your pattern recognition while you do it, and you can become more system 1 over time or type 1 over time.
Wonderful. How about I get to our second case? Enthusiastic trainee, knows all the options, but has a hard time committing to a plan. So here we go. Got a 6-year-old boy with leukemia, complicated by febrile neutropenia and mucositis, who developed septic shock. He receives volume resuscitation and requires vasoactive infusions. Unfortunately, over the next few days, he develops multi-organ dysfunction, including AKI and decreased urine output. The trainee on rounds develops a comprehensive differential diagnosis for this patient's AKI. But when she gets to the plan, she has a variety of options, diuretics, fluids, dialysis, etc. And then she looks at the attending and says, what would you like to do? So they see this every day in the PICU. How do we help our trainees navigate clinical scenarios when the next step is not clear, but there's so many options available?
All right. I love this. To me, this is management reasoning. And I know it's a term just applied to management planning, but it suggests there's a process for doing this, right? Which I think a lot of people, maybe 10 years ago, 20 years ago, they didn't know that there was a process for diagnostic reasoning until they talked about problem representation and hypothesis-driven data gathering. And all these terms have become more common in our vernacular. And I think the same thing has to happen for management reasoning because it's just seen as kind of the art of how we do things. And when it's seen as the art of how we do things, then a learner is going to be scared to like put their nickel down and they're just going to defer to you as the expert, right? But I like to break this down into two things. There's like a management script, and then you select things off of that management script. And the management script is going to be illness or kind of patient specific. So you just kind of give a full breakdown of leukemia and AKI and things I don't understand in a child. But there should be a management script of all the possible options based on that. And that's more just like knowledge, right? That a learner should come into your environment with. I think they usually stop there because they think if they just study more and they can get more options, they'll do better. But it's about how do they choose off of that kind of menu that I call it. And then it's about thinking like, what are the factors that influence our management reasoning? So there's like, how uncertain are we in what the diagnosis is? What's the risk benefit of each of these things? What are the patient or their families like goals and values and beliefs? And then there's like value things, like what are the cost of these different things? So those are 4 or 5 go-to, but there's even more like kind of contextual things there. But it's giving them that language to say, this is why I'm choosing things off this menu for this specific patient. And I think if we could all learn that language a bit more, then even us as practicing clinicians, we could actually verbalize why we're doing this in this situation, and we might not do it in another situation for a patient with exactly the same diseases and presentation, but we're doing different management.
Yeah, Andrew, what you're talking about here is exactly what I think about in the ICU. On a dream day, there's not 47 patients that are trying to come into my ICU. There isn't a full hospital that I'm trying to discharge patients out to. I've got a little bit of time, and I get to say to my learners, I'm just going to think aloud. Okay, second year resident or junior fellow, you've talked about diuresis, you've talked about dialysis, you've talked about fluid restriction, talked about oncotic pressure, like what's the role of albumin here? You've talked about these 4 different options. Let's walk through each of those. What's the risk of putting them on dialysis right now? And then they can talk about dialysis catheters, catastrophes that are associated with dialysis machines, et cetera. Then you could talk about, well, then why don't we just do diuresis? Well, is it fast enough? Is it going to knock their kidneys down more? I can acknowledge that they have built a beautiful menu. And then I can think aloud with them and say, let's think through the yes or no for each of the items on your menu. And then, and this is that, I'm not going to let you get yourself into a situation I can't get you out of. I'll say, you choose. What do you want? And sometimes they pick the wrong thing and I say, okay, anything except that. But if you've thought aloud, then you can let them lay their nickel down.
But it acknowledges there's a development there, I think, like focusing on the menu first. Because it's not just like, hey, what do you want to do for this patient? It's like, what are all the things you could do? Make sure they have that. We always focus on why you're doing something, but it's also why you're not doing this, right? Which I think will be helpful for the next situation where you might actually be doing that test or treatment.
And it gets away from the, in our unit, well, so-and-so loves to do dialysis and so-and-so never does dialysis and only does diuresis. And in fact, most of the time, attendings are pretty much in alignment. It's just that the patients are different. And if you can blow it out to a bigger view of, here's why I'm picking this right now in this patient, then trainees can start to recognize those patterns.
Oh, yeah. For this case, we have a septic leukemia patient, intubated vasoactives, AKI. Is the management script you're thinking for your trainees, okay, this is sepsis, AKI, and urea management script versus like a hyperkalemia management script versus like an early AKI management script, and you sort of break it down and you're like, no, for the PICU attendings, at this management script, that's when we dialyze. And at this management script, then we're still going to try with diuretics, things like that.
Yeah, and it helps you to put different patient filters on this, right? You and I know that if somebody says, if this is it wouldn't be an 8-month-old with leukemia probably, but if this is a 5-kilo patient, my management script choices are different than it's a 50-kilo patient. So all these things get filtered through, and if you don't talk that out loud so your learners can hear how you're thinking this through, and why this week the patient with AKI and sepsis is different than last week when it was AKI and hyperkalemia, then they're not going to be able to to see that you're not just picking at random. There's a really deliberate process to how you choose this.
And I think it acknowledges the separation between illness-specific or the diagnoses you were talking about, management, which is what they're so focused on coming out of med school and early residency, to the patient-specific things or the contextual-specific things like, oh, we're in the middle of the COVID-19 pandemic, so our resources are different, so that impacts the management we're going to do, right? But like separating those two things out can be helpful for their scaffolding and their cognitive load. And so then they can take that same management script to the next patient with the same conditions, but then they're just choosing different things off the menu because the patient's goals are different or the context is different or whatever it may be.
When I talk to my learners, particularly when I'm talking to junior PICU fellows, I say all the time that, hey, making a diagnosis is complicated. But to me, complicated means there's a lot of known unknowns. Taking a history is complicated, but I know what information I need to get. I know the known unknowns. Making a management plan, well, that's complex. There's all these different factors. It's more of a neural network instead of a tree branching diagram. There's all these different factors. And, there's this role of like an emergent fact can have a disproportionate effect on the rest of the system. So in a complicated patient, there's rarely a straw that breaks a camel's back. In a complex patient, that's where, hey, this kid was doing fine, and all of a sudden they tipped over the edge and flipped you the bird, right? We see that all the time. That's what night in the ICUs are, is that something that had been seemingly not that important in this complex patient was enough to cause a catastrophic effect. And management, I think, is all about recognizing that now you're dealing with complexity, and you have to be really thoughtful about what are the interplays between this complex system. And that's why it's a higher level skill, I think, than diagnosis. And you can't do it until you're pretty good at making diagnostic choices.
I agree. I like how you brought that up in terms of comparing it to diagnosis. I like to explain it by saying, at the end of the day, you either have pneumonia or you don't, or take any diagnosis. It's kind of the same. You either have it or you don't. So there's kind of that one right answer. Yes, in this case, you may have multiple diagnoses. There's more than one right answer. But in management, there's almost always more than one right potential answer. And it's about like prioritizing among those different things based on the patient, based on the situation. And so I think that's what brings more uncertainty into it, brings more complexity into it, and makes it a more difficult ability to learn.
Yeah, and to contextualize this, boy, this is what I expect from people who've rotated through the PICU once or twice. That's where I'm going to get into like the complexity of management choices. Could you imagine, Alice, if on somebody's first weekend in the PICU, you were like, so do you want to do dialysis, diuretics? What are you thinking here? Right?
Oh,
like
yeah.
you'd get eyes and like they wouldn't come back.
No, you terrorize them. Totally.
Right. So you have to wait. This is a more sophisticated skill. This is like, I'm impressed when my first year fellows do this well in their first 6 months.
Yeah. And it's also something you mentioned is the coping mechanism of as a trainee. She always wants to dialyze, right? Like, everyone here is on vancomycin. Don't they care about, or like, you don't manage bronchiolitis. And I feel that that's a coping mechanism for not understanding the very like specific management scripts for different patients. Is to your point, we're all kind of managing these patients the same way, right? It's the nuances that you need to understand. But
and that often I get to manage patients, quote unquote, my way, because my partner's already done it their way the week before. So they've accomplished their goals. And now I get to do the next thing. That's really hard to explain to trainees.
You see the same thing in the medical school world when they're coming from pre-clerkship into clerkship. They even have a Google Doc at our institution of how each attending likes their presentations. And
wait, that's awesome.
Yeah. And
helping each other. It's good.
Exactly. They're attempting to help each other. But I think not acknowledging that they just like them differently because one, they're a different service, and so they care about different things, but also it's all about the clinical reasoning and what's going on with the patient. It's not that they just like to hear these things as an individual.
Oh, yeah.
Reflecting on what you shared so far, I think that there's value in demonstrating to trainees how we process all the data of these complicated patients and complex situations. Kind of, as MJ, you were saying, when you talk about the pluses and minuses of dialysis and diuretics, et cetera. And I feel like as recently going from a fellow to an attending, as a fellow, always want autonomy. You want that ability to make a decision, help a patient and see the results of that decision. And I can't think of a better way to get autonomy as a trainee than having conviction about a plan and a contingency if that plan doesn't go well. And I feel like as educators, being able to communicate that to them and showing them that has to be so important. Do you have any tricks or any tips, like as over the continuum of as fellowship from first year fellow to third year fellow, how to empower fellows to have that conviction, maybe if they haven't quite developed yet, or to helping fellows develop that commitment to a plan?
Yeah, that's good. I like commitment instead of conviction. So like the commitment to a plan is empowering them to say like, well, what's the worst? What if we guessed wrong? Then what are we going to do next? And encouraging them to talk through that out loud, right? We're going to go back to my joke of like in the ICU, we're like fluid, just kidding, Lasix. But that's part of our gig is empowering the learner of make your best guess. What are the signs that you guessed wrong? And what's your plan if you see those signs? And I also think role modeling is really important here. The number of times on night rounds or during sign out or during regular rounds where I say, all right, I'm going to think out loud for you guys so you hear how I'm processing this. And doing that with low stakes and high stakes decisions. Now, I'm not doing that while we're cannulating somebody for ECMO. The cardiac surgeons wouldn't appreciate that. But I am doing that when I'm making a decision of, I know you had Sapna Kachadkar on here a couple of months ago. Hey, is this pain? Is this withdrawal? Or is this delirium? Let me talk through how I'm thinking through this differential, or talking through how I'm thinking through how I want to manage this. And I think taking a quick pause to reflect on that and demonstrating it for your learner, then role models, this is what I want to see from you.
Yeah. What other round strategies do you guys use to encourage this?
I was going to say, well, there's some system-based things too, where you have to actually structure, the educational environment to promote autonomy. But like, I'm told from some residents that I give them a lot of autonomy. I have never done it, any different, but it suggests to me that there are attendees that don't give them a lot of autonomy. I think this is a real issue because Like as MJ said, we can say, hey, we want you to put your nickel down and we want to empower you to make decisions. But if we just take what they say and then we go off and we do our own thing, there's no real reason for them to do that. Like we really have to give them ownership and promote autonomy in what they're doing. So I think it's kind of taking a step back and thinking about what's a critical management decision, let's say. Like, do you want to give Lasix or not? Then is it 40 IV or they say 60 and you're like, nope, we're doing 40. It's like, does that really matter? Or do we want to start and then we move it up from there? And so allowing them to have more ownership in what they're doing, I think is a big thing.
Oh, yeah. What are the structural things?
I don't know. I've been at UVA for 8 years now, and then I was a resident for 3 years before that. So I just think I see different services like internal medicine. We structure it where I think the expectation from the beginning is that residents take ownership of their patients. They feel empowered. They make a lot of decisions. I see other services where it's not so much the same. And I don't know how you feel about that, MJ, because I don't know exactly why, but I just think there's a certain expectation that's kind of ingrained in the culture of a given residency program or medical school as to how much ownership the learner is expected to take and how much autonomy they get.
I don't know if we'll have time for this, but I'm thinking all the time about, like, I've got attendings who will be like, oh, let's get a BMP instead of a CMP. And I'm like, oh my God, let them have it.
Yeah.
Like, just let them have it.
No, that's totally, yeah.
And the number of times you think like, I wouldn't do it that way. But I think with a little bit more gray hair comes up, it probably doesn't matter. You're picking something that's probably right enough. Like perfect is the enemy of good. I think that's the strategy with autonomy.
Yep.
You're not going to hurt them. You're probably moving the ball in the right direction. Let's let it ride for a while.
It seems like a skill here is when you're asking a trainee a question, a management decision, you need to have a range of right answers in your mind.
That's right.
You're going to be happy with. And if it falls in that range, you have to just put your nickel down as the attending and say, we're going to give this autonomy to the trainee and we're going to monitor, right?
And just the same, don't ask and offer autonomy if you're not planning on giving it, right? The pediatrician is, I'm not going to say, do you want this IV? I'm going to say, are we putting this IV in your left hand or your right hand? And I think that's true as you're giving your trainees choices to make. I'm not going to say, like, do you want to intubate this patient or not if it's obvious that we need to intubate that patient?
Yeah. You want a Miller 1, Miller 2.
That's right. That's exactly right. Yeah. Using a Miller or a Mac. Let's get going.
In the pre-meetings, we talked about a management pause and equity pause. Anything to add about those concepts?
So those are two techniques that I really like. It goes back to what we talked about in case 1, where it's that more deliberate practice, like slowing down, utilizing your type 2 thinking. The management pause, or it's actually called like a cognitive forcing function. So it's a way of saying, stop, you have to think through these things explicitly. Like, what are our options here? What are our priorities? There's different ones out there. Some are more focused on high value care. Like, is this test going to change management? What are the patient's goals and values? What is the cost? Is there like a less costly alternative? That's an example of a management pause. So you can frame it however you want around a different kind of factor that influences management. But I think it's one of those things, if you use it, you have to take it with you and do it every single time, because we're just not that good at saying, oh, now I need to use it. Now I don't need to use it proactively. Like, we can only think about that in retrospect, perhaps even after an error was made or we did something we didn't like.
Yeah, and I think the equity pause really helps. I think about this all the time with the body of literature that suggests, hey, if you are from a family that English isn't your first language, you get different care in the PICU than if you come from a family where English is your first language. And so that equity pause can help me say, hey, is there a choice I'm making here because it's a drag to get the interpreter, or because I'm not sure I can adequately explain this risky procedure? Am I avoiding, not necessarily the standard of care, but am I avoiding what I would want if my child were here because things are tricky? And I think that equity pause is another mechanism that helps you slow down and say, is this what I would want if this were my family member?
Yeah.
I like how you said family member, because I think that's key to personalize it that way. To me, the need for this comes from, we have to deviate from the standard of care so much because of resource limitations or whatever it may be. It can become too easy to just say, well, we don't have any other options. We just have to do this. But if you put it in that aspect of like, what if it is your mom or dad, or, what if it's somebody important to you? Then maybe you go the extra mile to go get social work involved or go get someone else involved to like really help that person and get closer to the standard of care.
Oh, yeah.
Before we move on, I wanted to give you guys an opportunity to plug your Rapid Evaluation Assessment of Clinical Reasoning tool, or REACT. Tell us about that and how it's used.
Yeah, well, as we were starting our clinical reasoning coaching at UVA, we recognized that there's this pattern of learner, and that's the I get to an urgent situation and I freeze. Or I hear there's an urgent situation, I just don't go.
Yeah.
Right? I think about the number of times where, as a PEDS resident or a PEDS attending, I'll walk into the workroom in the aftermath of resuscitating your patient. How come you're putting in epic orders? And I used to get real mad until I realized that a lot of these trainees haven't had the coaching for what do I do when my amygdala gets activated. As soon as it's on, how do I get to a comfortable, repeatable process so that I can assess somebody in an urgent situation? And so the React tool came to help with, recognizing, hey, patient safety's got to be paramount. But is there sort of a standard approach you can take either in simulation or in real life to help you think through what are the different domains that are required of somebody in an urgent situation and what level of skill does your learner have within those domains? And it's a lot of the things we've talked about today: management, recognizing hypothesis-based choices.
Yeah, so we describe specific behaviors across a range of performance for each one of those factors. And it's a one-page template, and it gives, the upper level resident if they're working with an intern, or the attending if they're working with an intern or a resident. It gives you kind of a language to observe what's going on and give feedback in the moment, or I think more often right after your work with the patient. Because as MJ said, this really came from, these were learners that we had actually worked with a lot in our remediation program. We had done a lot of coaching with them, and we were like, they're better, no doubt about it. But all of that coaching was done in this calm one-on-one environment, right? And so
very safe.
And yeah, very safe. And so we felt good about them. And then they would go back into their own training program, and we would hear pretty frequently that, well, it's these urgent or emergent situations where they're really struggling. And
where now they're struggling.
Exactly. Because that was such a different context than where we had employed our coaching strategies.
And simulation's a great way to practice that. But I think giving the evaluators a framework, I know you guys as PICU attendings have seen residents respond to emergent situations and think, there's a lot there. I can't take all that on today. But it helps you break it down into a bite-sized piece of, I'm thinking about times where I'm like, hey, did you notice X, Y, and Z on the monitor? And now we can just have a discussion of what's your situational awareness? Or I heard you giving a lot of orders. In your communication style on that urgent situation, have you considered these behaviors? So it helps me also break it down into really bite-sized pieces. Because remember, after an urgent situation, most learners don't have the bandwidth to go through every last thing that they did right or wrong. This, I can pick an area and say, let's settle in with how you're communicating during that for a little while. Or let's think about how you were able to test hypotheses or, different domains in that behavior. And it's, like Andrew said, it's a one-page sheet. I don't carry them around with me. But if I'm going to the sim center with learners, I pull it out all the time and say, here's the playbook. This is what I'm going to look at while you're doing this case. And sometimes just saying, here's the playbook, here are the behaviors you need in an urgent situation, can unlock some of that freeze frame that you see in learners when they don't know what to do first.
Wonderful. We'll be sure to cite that in our show notes here for the listeners. Any more management tips before we move on to our third case? Wonderful.
All right.
Yeah, we've accomplished all of medical management. It was 28 minutes. So that's pretty good.
I know. Short enough for a program director, right? To listen. And so we've got mini case number 3 here. This is the first year critical care fellow who struggles to concisely hand over complex patients. An oldie buddy goodie. So
we know it, you love it.
We know it, we know them, and we love. So when handing over a patient with shock due to an unclear etiology that persists after fluid resuscitation to the on-call team, a first-year fellow provides a detailed explanation of the past 24 hours of events, of the patient's care, but fails to organize the story in a way that clearly describes what is needed next for this patient and what the on-call team should expect. So you're sitting there, maybe you popped into the room, maybe your group does a big fellow attending sign out. How do we help our trainees succinctly communicate a patient status here? How are we getting them to describe their anticipated course, really set the night team up for success?
I think this gets to 2 developmental milestones, right? At some point, you just got to let early trainees run with this. I had to stick cardiac, and then I gave fluid, and then I gave Lasix, and then I went up on the pressors, and then some of it is a war story, and they've got to run through that in their mind.
Live. Yeah.
Some of it's just that's developmentally appropriate. There are folks who are unable to get away from the, you're never going to believe my night, bro. And I think those are the ones we want to address here. Because I think if you tell a story as a narrative for here's how it affected me, it takes too long and everyone loses attention span because every ICU doctor's favorite color is shiny, right? We are an attention deficit bunch.
You only have 5 seconds.
That's right. So I think instead what you want to really get to here is this goes back to our idea of the ICU as a hypothesis-based physiology lab. So I want to empower my learners to say, this patient had shock. I thought it was distributive. I thought it was cardiac. I thought it was dehydration. Here are the interventions I made. Here's how they responded to those interventions. Here's what I would think about for the rest of the day. So I think if you can take the story time fellow, and I bet there's people who trained with me who are like, girl, you were a story time fellow.
We're not saying we don't love a story, okay? You got to separate it from
That's
right.
But I was a story time signer outer. Like I was like the bard during morning fellow sign out. But I think there's a difference between the fellow camaraderie story and I need to have the skills that if I'm standing in front of a group of surgeons or if I'm standing in front of a multidisciplinary team, I can give a hypothesis-based story. The patient presented with these findings. I thought this was the illness script that we were in. I chose these management strategies. Here was the result. Because that's what we do all night long.
Yeah.
That's what we do all night long. And then that's going to prevent people from reinventing the wheel. When you tell the story right, then people don't do the let's try extubating again and just see what happens. You've already done that hypothesis.
I was cringing a little bit when you said that.
Yeah.
Yeah.
What I think might be helpful is empowering trainees to be as specific and simplistic as possible, but no more, right? Like speak in diagnoses rather than symptoms if you're confident in the diagnosis.
Yeah.
And try not to overcomplicate things if you possibly can. It's so easy to describe, but it's so hard to implement.
Oh, I think signing out the ICU, it's the hardest procedure a fellow learns in their first 2 years. I think it's as hard as the A-line in the 3 kilo with vasoplegia. Like it's just a really hard thing to do. And so I think you've got to practice.
Is it hard from a communication standpoint or is it hard from a reasoning standpoint?
Yes.
So I asked that because I think there's like two, which I think you started out by saying, these are like two skills in one. There's like the ability to communicate, which you can struggle with that just more generally, right? Kind of in all aspects. But this is like an applied reasoning task. Like this is where the rubber meets the road of like, you have to be concise and you have to tell me everything that matters, but nothing that doesn't matter.
And the risk, if you tell me something that doesn't matter, there's actually a downside to that. The person that includes too many details is going to send their listener down a path that they don't want. So, the classic example in peds is somebody's like, this unvaccinated child came in and all of us are like, oh man, is it epiglottitis? Like, is it a meninge? What's going on? And sometimes that's completely unrelated to why the patient was in the ICU. But because you've given me that little tidbit, my illness script scattering in my brain has gone in the completely wrong direction.
No, you're like, it's a TBI patient though, right? Like, you're
Right,
like, wait, confused as to,
Right, this patient was in a car accident, and I don't think that has anything to do with their response to measles.
Yeah. But Andrew, is what you're saying for the PICU fellow who's telling the whole story of the night and not giving you those closed evaluation management loops? Like, we thought it was this, but it's not. We thought it was this, but it's not. Maybe because they don't know what diagnoses they're testing. Is that your concern here? Well,
I'm saying like, I like the problem representation framework, which is, I think Zach said, a very simple framework of like, who is the patient? What was kind of the temporal onset of their symptoms? And then like, what are the key signs and symptoms? That's more for like an initial presentation. So to your point, you could add like, then we decided it was this and then we tried this and it worked or not. To me, the importance of that framework is it's simple, but it also acknowledges, I think they're used to thinking about that framework in the context of diagnostic reasoning. So they know if I say a word, if I include something, it matters to the listener. Like the listener is thinking, oh, what's my illness script for that based on that term? It gets them to be more concise with their language and thoughtful about if they're saying something versus they're not, versus, oh, I'm just talking to a friend and I can tell you a whole story and all my thoughts on what's going on.
I remember thinking as a fellow that sign out to the evening attending was such a tricky job. I can see the attending's face in my head where I'd be like, this is a patient who's a door of width. And he'd be like, no, I've got it from here. Complex congenital heart disease. You're through the fluid resuscitation. Next. And I was like, are you annoyed with me? Did I not tell you enough? But what I didn't recognize as a junior trainee was he's got all the illness scripts. He actually has it from here. If I say post-op day 1, sick heart, now we're diuresing, he's like, okay, I got it. And that it takes some courage and some experience to get to, that's what we're really listening for.
I feel like trainees, they might not have that framework already set. Like, what about this case is typical? What about this case is atypical? And sometimes it just takes a few years.
Yeah, that's right.
figure
That's
it out.
why you have to do it. And we've all seen the glazed over eyes where you're like, I got to move this along. I'm not doing this right. It's part of learning. You got to do 10,000 hours of it to get it done. But you also need somebody to have role modeled or to have said, we thought it was hypovolemic shock. Volume didn't work. We realized we had guessed wrong. Here's what we did instead. Because if you don't answer those questions, you might run into the next morning. Someone's like, why didn't they just give him a bunch of fluid?
Yeah. And they repeat that mistake.
That's right. Or they repeat that experiment with the same results, and maybe it's a little worse based on where that patient is on their Frank-Starling curve.
There's also a cool unexplored kind of reasoning area here, which is we've talked about diagnosis, we've talked about management, and this is a shout out to one of our colleagues, Jessica Dreicer, but she's studying prognostic reasoning, which there's not much out there about it, but she claims it's like a third distinct kind of reasoning process. And so if you break that down, I think sign-outs or handoffs are where it really comes into play, because she says it's like two processes. It's like, are you sick or not sick, which we talk about all the time, right? Like that intuitive decision of sick or not sick, but then a forecast from there as to what's expected to happen over some time frame. So it could be short term, like just over the night, or, more traditional prognosis is like over years, what's going to happen. I think that's a skill we don't teach. Like we're focused on, yes, was the diagnosis right? What have we done so far? But really in sign out, it's like, are they sick or not right now? And what do I expect to happen over the next 12 hours, which takes diagnosis into account, takes response to management into account, but it's kind of its own thing.
Yeah, it's like being able to talk about what's the slope or the trajectory of this patient, as opposed to where are they at this point in time. And you think about really good attending sign-outs. They're the ones that can look at you and say, you're only in reactive mode with this child tonight. I don't expect anything to come. Versus the ones who are like, put on your roller skates. This 3-kilo child's going to keep you super busy.
Do you two have any ways that you give feedback or work directly with trainees? And I'm also wondering if you, in your attending life clinical practice, have any ways that you reflect on your own sign out, talk with people about it, anything like that?
Yeah, I think what I try to do with my trainees is, particularly in some junior trainees, I will pull them back to, here's what I really need to hear. What is the patient's active issues right now? What did you do about them today? What are other systems that are involved in this? And I will sometimes say like, wait, I'm lost in the sauce here. It sounds like this is a patient who had a heart repair a week ago, and now we're currently dealing with some complications from that, like chylothorax, or we're dealing with some complications like that, like an arrhythmia. And here's the arrhythmia management you've done, and you're in a pretty stable place, but now you need to tell me what to do if that changes. And sometimes like really breaking it down to here's what I'm exactly listening for, and you haven't answered these questions can help focus them. I think that's actually a really important skill. What I don't like is if a fellow is signing out and the daytime attending's like, what she means to say is blah, 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 blah. And I'm like, well, I know you know, gray-haired attending. What we really need to do is have this like moment-to-moment coaching of like, here's the data I'm listening for right now. Can you tell it to me? And if not, tomorrow I'm going to be listening for this. This is why I'm listening for this data. This is why this information is really important right now.
And I think you can force prioritization as kind of a coaching skill. Like you can do that in the diagnosis world too, right? Like you only get 5 history items and 3 physical exam things. So you can assess if they know what the high yield history items are or the high yield exam things. Well, here it's like, what if you only had 30 seconds per patient?
Or what if you could only tell me the 5 most important things about this patient?
Yes. Because we actually had a huge problem in our residency. I mean, this was 5 or 6 years ago with sign out taking forever at night. And so we had
internal medicine.
Exactly.
Right.
The sodium.
Yeah.
Exactly.
Let's talk about the hypertension management and then not change a thing.
No, but what's interesting is we had a colleague study it, and they would come around and literally stand beside you and time it. And the quality of sign out greatly improved. Like when she was right there, because then it was almost a competition and it's like faster. But then you could also quickly identify people that, wow, yeah, you achieved the time cutoff, but
I don't know what actually happened.
Yeah, exactly. And so that I think like forces you to get down to like, what's the key underlying deficit occurring here?
There's some trainees who still feel like if I don't tell you, you don't know that I know it. And if you don't know that I know it, I'm doing a bad job. Right? Like I'm thinking about the trainee who's like, and then we repleted the potassium. Would you like me to give you the mg per kg? And I'm like, no, I've already had a seizure. I'm not listening to you anymore.
Yeah, that's a lot of work that they've done, right?
That's right. But they're like, that actually,
I
had to like, of course it's a lot of work. Of course.
Or doesn't acknowledge there's an entire electronic health record that you could access at any time over the night.
That's right. But it's that trainee feeling of, if I didn't say it, you don't know that I know it.
Yeah.
And I think there's a lot of meta communication that goes into, you ready for another analogy? Sometimes sign out's a little bit like a burlesque show. If you just take all your clothes off right away and show me everything, I'm not going to pay any attention. But if you tease the story in the right way, you have my complete attention the whole time.
Don't tell a story. Tell a tight and emphatic story that's also fascinating. Okay.
I want a tight 3. That's right. But it is like I use that burlesque show analogy all the time, much to the dismay of our program director.
Sure. Yeah. Don't just tell a story, but also make it fascinating and make it very short.
Or at least make it know exactly what I need to hear. I think it's the hardest skill in PICU fellowship. Signing out between 18 and 30 complicated patients in a set time domain, recognizing which patient you can be like, that homie who's been here for a year, same as he ever was, versus this patient is actually different and we're going to have to wallow in the mud for 4 or 5 minutes so that you can get through the night. It's a hard skill.
This seems like another place where it might be easy to label a learner who's struggling as having a medical knowledge deficit, where it might be a scaffolding or organization issue.
Yeah, I see that all the time, where people are like, she just doesn't understand that disease process, or she just doesn't understand. And then you're like, I don't know, her in-training scores are pretty good. Or she smashed step 2. That's not the issue. The issue is, I don't know how to distill this into something palatable. And when Alice and I are involved, palatable and fascinating.
Yes.
Is that too much to ask?
Listen, in DC, the sign out, you walked around the unit, and so you knew if you were talking too long because your senior fellows would just walk away. So,
But sign out's also a vacuum. This is Andrew's point. Like if I tell somebody that they have a half an hour to sign out 8 not that sick PICU patients, they're going to take a half an hour to sign out 8 not that sick PICU patients.
Yeah, totally.
If they have a half an hour to sign out 18 medium sick PICU patients, that sign out's pretty good.
Right, because there's a thought that just more information is always better, but it's not, right?
Yeah, that's right. It's a receiver bandwidth issue,
yes,
not an information issue. And I think that's what you have to train people to sort of speak to.
But the forcing that prioritization helps you figure out, is this a communication issue or is this a clinical reasoning?
Yeah, I'm thinking about a learner who I'm going to say, tell me the 5 most important things about this patient and see what happens. I'm glad we had this talk, Andrew.
Well, this has been fascinating. I have such enjoyed having this educator perspective type episode on PedsCrit, something that we haven't had much in the past, but something that we hope to do more, thinking about diagnostic reasoning, management reasoning, and helping our trainees navigate complex communication scenarios. As we move to the end of the conversation, anything else that you'd like to mention or plug or direct our listeners to?
I got one last thing for you guys, and it goes back to a question that Zach had to Andrew early. It's this idea of, hey, sometimes trainees don't like the Socratic method. Right? I feel like when we were all coming up, it was the job of the attending to probe our explanatory depth. How many questions can I ask before you're like, I don't know? And at some point, the attending should know more than the trainee. That should be true. But that can kind of feel uncomfortable. I have lately started sitting next to a trainee, and we will probe the explanatory depth of ChatGPT or AI for non-HIPAA problems. And it is a nice way to sit next to somebody. Right now, we're allied, and we're going to see what a big dummy ChatGPT is, yes or no. And it's like side by side. We used to call it pimping. It's like doing that side by side instead of them feeling like they're on the spot. And so there's some clinical reasoning work that you can do using generative AI now. That's a nice, gentle way for trainees that don't really like being on the hot seat. Explain why albumin helps Lasix work. Explain why albumin doesn't work that well when your albumin's already 5. Maybe every surgeon in the world could sit next to me and we could ask ChatGPT that. I don't know.
Oh, that is fun. That's a fun bit. I have a fellow who will ask a diagnostic question, HIPAA, through our Northwell AI platform, which is HIPAA compliant, on rounds and be like, well, let's see what they think. And it's fun.
Yeah. That is a burgeoning area for clinical reasoning work with your trainees, particularly the ones who you're like, if I come at you with a direct question, for those of us who weren't raised in the Northeast, it's going to feel a little jarring.
Well, not only the why, MJ, but I just want to point out you've led a curriculum for our med students as using AI as kind of a consult to get at that early hypothesis generation. So it's not like you see the patient's chief complaint, and you just go right to AI. It's like you see their chief complaint, you generate your own differential. And then once you've reached kind of the bounds of your own knowledge, you go to AI and say, what am I missing here? And it expands it out for you. And then you use that to go in.
Well, and then you could say, no, that's a dumb idea. Of course, it's not psychotic.
Exactly.
It happened 2 days ago.
Yeah.
Well, Dr. MJ Sacco, Dr. Andrew Parsons, we have had so much fun speaking with you today. Thank you so much for your time. We're very excited to share this with our listeners.
Thanks, guys. This was a lot of fun.
Definitely. Thanks for having us.